Okay. So before moving on to Gaucher disease, there's just one aspect of MPS that I completely forgot to mention yesterday. But it is clinically important. And I also forgot to discuss it in clinic. And that is coagulation in MPS 3. So in MPS 3, you get abnormal APTT. And this is probably related to the circulating heparan in the blood, and it's unrelated to the clinical severity. So it can be seen in very severe abnormalities, can be seen in very young children and vice versa. So I don't know why that is the case. But the abnormality increases during surgery. So for example, we had a case of MPS 3A who by coincidence also had DMD, and he was scheduled, he had an adenotonsillectomy, and before the adenotonsillectomy his APTT was not checked. They took out the adenoids, and immediately he started bleeding profusely at surgery. He required something like several units of blood and FFP, and I think cryo to bring this under control. The APTT shot up during surgery, stayed up, and then over the next 24, 48 hours, it's gradually settled. And we were puzzled as to the reason for that. But we thought that this must be because the adenoidectomy had released heparan by virtue of tissue damage. By virtue of tissue damage, it had released heparan-like substances into the blood. And anyway, he survived. But after that, we made it a routine practice to check APTT in all Sanfilippo patients. It's particularly abnormal in Sanfilippo disease. But we get slight abnormality sometimes in other, especially MPS 2. So all children with Sanfilippo disease at presentation should have their APTT checked, and if they are due to have surgery, they should have it repeated. Whether there is a higher risk for adenotonsillectomy, I don't know, or why that should be the case. I've seen other, especially adenotonsillectomy, other operations don't seem to have the same risk of bleeding. And I don't know whether it's something to do with the saliva or other chemicals in the oropharyngeal cavity. Anyway, I just thought I'd mention it. So we'll move on to Gaucher disease now. We know it's a commonest lysosomal storage disorder, although probably Fabry is as or more common now in some countries. It's recessive. Acid beta-glucosidase is deficient, and it accumulates glucocerebroside. First described by Gaucher in 82. The infantile forms were described in 21 and 27. Chronic neuropathic by Hellborg, the Swedish Norrbottnian variety in 1959. The classification into 3 types was proposed in 1962 by Paige Kaplan and her colleague Ron Hudson. The enzymatic defect was described by Roscoe Brady in 1965. As many of you may know, he sadly passed away recently. And the first trial of ERT was in 1990. The gene is localized to IQ21. It's cloned and sequenced 11 exons, 10 introns. There is a pseudogene that's very important to remember, with a 96% sequence identity, which contains a 55 base pair deletion. And many mutations are the result of recombination between the gene and pseudogene. There's a gene-rich locus with at least 7 genes and 2 pseudogenes within a 75 kb stretch. The first mutations were described in the 80s, and well, probably over 300 to 400 are now known, mostly missense. And that's important because it differs from many other LSDs in that they're mostly missense mutations. So these are some of the common genotypes. You can see the N370S homozygosity is the commonest. Then compound heterozygotes for N370S L444P, and then you sort of work your way down. But in some countries, L444P this is from the international registry. In individual countries, L444P homozygous is much more common. In Japan, it's virtually unknown. Actually, you don't see the L444P homozygotes. You see very unusual mutations in Japan. So we shouldn't look at the international registry as being representative of individual countries, because this data depends on the contribution of individual countries. And I think Japan has contributed very little to this particular data set. The allele distribution is very striking between Jewish and non-Jewish. The N370S is much commoner in the Jewish, as is the 84GG. The 84GG is virtually unknown outside the Ashkenazi Jewish population, and homozygosity for 84GG is lethal. Okay, so this is very important when counseling Ashkenazi Jewish families. The L444P is essentially, again, very uncommon in the Jewish population. So if you go to Israel, you don't find many L444P homozygotes. The enzyme defect, it's lysosomal beta-glucosidase. It's homomeric, so it's repeat units as opposed to heteromeric. It's a peripheral membrane glycoprotein with 497 amino acids. It's present in all tissues, but the expression levels vary, and this may correlate with the expression of the reporter gene under control of the promoter. That's just a theory. I don't think it's been definitely proven. The enzyme is targeted to lysosomes. We discussed this a little bit earlier, independent of mannose-6-phosphate receptors. LIMP2 is the receptor, and it's under control of this gene SCARP2. This was shown in 2007. It's membrane-bound, not cytosolic. It binds to enzyme in the ER and delivers it to the lysosome. And this enzyme requires sapacin C for its action. So sapacin C has to be in the same compartment. So this shows you sapacin C acting on the gene. And basically the effect of glucosylceramide. Glucose riboside breaks that down to glucose and ceramide, and all this takes place in the lysosome. You get these Gaucher cells, the wrinkle silk cytoplasm. Now, we talked about residual activity in a previous talk, and this is just some work done in 2005. So this mutation, you get about 32% residual activity, whereas with the L444P, you get 12%. And this suggests that patients who are homozygous for this mutation may have more severe disease than patients who are homozygous for this mutation, and that is true. In fact, homozygosity for N370S, these patients may be virtually normal. In many patients in Israel are not even treated because they're so mild. It's important to know that there is a second beta-glucosidase, it's GBA2. It was first described by Sonja van Wiele from the Netherlands in 1993. It is non-lysosomal, and its deficiency does not result in Gaucher disease. There are two substrates, glucosylceramide and glucosylsphingosine, which is the lysoform. Okay, so this shows this glucosylceramide. Those are the two substrates, and these are the products. Okay. Now, some work done many years ago, it is actually very difficult work to do. You can imagine looking at brains, but the group examined the brains for glucosylsphingosine levels and admitted the number of brains was very small, but in type 1, the level of glucosylsphingosine was normal, whereas in type 3, it was grossly elevated. Now, okay, it's a small number, but you're not going to get that many human brains to analyze, so we have to take what we can get. And it does suggest that there may be a role for glucosylsphingosine in the pathogenesis of the neuronopathic variety, or the neuropathology. And of course, you can see in type 2, where there were more brains, it's even more highly elevated. So the Gaucher cell is a small cell with eccentric nuclei, wrinkled silk cytoplasm, and it's of macrophage origin, again very important to remember. And that's why it's so amenable to enzyme replacement therapy. You should also bear in mind that storage alone accounts for less than 2% of the visceral enlargement. You get neuronal loss in the neuronopathic forms. This is the hippocampus, showing the two regions, CA1 and CA2 of the hippocampus, and that's normal, and that's in type 2, and you can see the gross neuronal dropout. Demographics, so the age distribution in the Gaucher registry, this is from some time ago, but it still stands. The vast majority of patients are in this age group, so relatively few at both ends. That is slowly shifting because more and more patients are getting picked up, diagnosed in early childhood. So this is just to show you that the vast majority of patients have type 1, a smaller number type 2, and type 3 intermediate, which is what you would expect. There is some genotype-phenotype correlation. The N370S is felt to be neuroprotective. Quite why is uncertain. Homozygosity for 84GG is lethal, as I said. Homozygosity for the rec alleles is lethal, and certain genotypes may predict neurological disease. There may be a role of epigenetics. So this paper or publication came out quite recently. The contribution of epigenetics to the phenotypic variation in a set of monozygotic twins with Gaucher disease. So these were two twins with the same, obviously the same mutation. One had neurological disease and the other had no evidence of neurological disease. And they showed DNA methylation differences. The twins were discordant. Monozygotic, they were homozygous for the for a GBA1 mutation. Only one developed severe neurological problems, and they showed a DNA methylation they studied DNA methylation patterns of CPG islands from genomic DNA, and they showed that there were differentially methylated genes in the more affected twin. Now, whether that's entirely responsible, but I think it is interesting, and there is a lot of interest in why there is so much phenotypic difference in SIBs with Gaucher disease with the same mutation. And I don't think we fully understand the reasons for this yet, but epigenetics may have a role. There is secondary pathology. There's an autophagy block. It has profound effects on mitochondrial function. There's a reduction in the oxidative phosphorylation levels. There's mitochondrial swelling, there's reduced ATP levels, and there's a reduced mitochondrial membrane potential. So we know the three phenotypes. There's some high-risk genotypes, homozygosity for L404P, for D409H, and compound heterozygosity for the above plus rec alleles. So as I said, the variation correlation is so far, sorry, unexplained spelling mistake there. But again, the recently identified conserved non-coding flanking sequences which regulate transcription could explain this. So lots of theories coming up about phenotypic variation, and I think we'll just watch this space to see what develops. There's an ethnic predilection. Type 1, predominantly Ashkenazi Jews. Type 2 and 3, mostly pan-ethnic. There's some evidence of founder effect in type 3. This is a map of Sweden, and that's the north of Sweden, towards the Arctic Circle. This is the Norrbotten region. And what happened was that the people migrated up north, and basically from Sweden they don't migrate into Finland. Okay, that's out. So up here there were dense forests, and so they had to stay here, and they settled. They were largely agricultural. They settled on the land, and virtually all known patients in this area descended from two families. So very striking founder effect. So in the 16th century, the Swedish king decreed that all births, deaths, and marriages had to be recorded in churches. So in the 1950s, when Hilborg and Ericsson and so on wanted to do their research, all they had to do was go to the churches, and the family records were all there. It was very easy, actually, for them to draw out the pedigrees. So here you can see this is from 1630 to known families and all the known descendants. That's become a bit more diluted now, but I mean, I've been to this clinic, and it is very striking. They all know each other. Oh, it's really quite extraordinary. So moving on to clinical presentation, this is Gaucher disease as a whole, okay, not just type 3. You get 6 splenomegaly, hepatomegaly, thrombocytopenia, anemia. I think this, you all know this. Other presentations important: non-immune eye drops, we discussed earlier. Collodion baby, that's another important. Now, there is a lot of discussion and controversy about this. Is the distinction between the three phenotypes clear-cut, or is Gaucher disease a continuum? And some people say it is a continuum, and other people disagree, and I'm not going to go into that. I'll just say that that is a discussion at the moment. So, visceral, you get skeletal disease, marrow infiltration, Erlenmeyer, Flass deformity, osteopenia, vascular necrosis, lytic lesions, fractures. So marrow infiltration, the vast majority of patients do have a degree of marrow infiltration. They can get, this is the Erlenmeyer Flass deformity, you can see the patchy infiltration there. Femoral neck fractures, pathological. The MRI appearance in normal children is age-related, with essentially red marrow being replaced by yellow marrow, with fat coming in as the child gets older. But strikingly, so here's an MRI of a normal child at 6 months and a normal child at 8 months, and you can see the yellow marrows come in. And that's a Gaucher patient at 7.5 years, about the same as this child, but actually the MRI looks more like this, because there's hardly any normal hematopoietic tissue. The skeletal disease tends to be asymmetric. It is resistant to treatment. There are two factors that are predictive of avascular necrosis. One is the interval between the onset and start of treatment. So the more the delay, the higher the risk. Okay, and the other is total splenectomy. So here you see graph number of bone crisis, years of treatment. So In patients who have had no prior bone crisis before starting treatment, they tend not to have many further bone crises once ERT is started. So this is 8 years on ERT. Okay? Whereas if you'd had prior bone crises prior to the start of ERT, then even with ERT you continue to have bone crises. So if you can get ERT in before the first bone crisis, that has a profound effect on preventing further bone crises. This is the incident rates of AVN increases with increasing duration of time elapsed between diagnosis and commencement of ERT. So if the interval between diagnosis and commencement of ERT is less than 1 year, the risk is about 8, whereas if it's 30 plus years, it's much higher. So basically, the longer you leave it, the greater the risk of avascular necrosis. Pulmonary disease takes many forms. There is radiological parenchymal infiltration in 15%, and 17% of patients show low FVC. There's pulmonary hypertension with pulmonary intravascular macrophages or PIMS, and plexogenic arteriopathy. They get hepatopulmonary syndrome. They can get pulmonary hypertension with a high right ventricular systolic pressure of greater than 35 millimeters, 7 to 15%. So that shows you a typical X-ray of a child with type 3 Gaucher disease. This is classic Gaucher lung disease, and it's very, very common. It's probably, we don't look for it closely enough. It may present in infancy. Typically, they present with recurrent episodes of cough and wheezing. So they present with like asthmatics, and they're treated as asthma because people aren't aware that this may be related to Gaucher lung disease. They can get post-operative hypoxemia. So after any surgery, they take much longer to recover than a normal child. So that's an X-ray of interstitial lung disease. Again, same child, CT scan. So CT scan is quite sensitive in picking that. We don't often do this though, because normally X-ray is sufficient. This is showing you these. This is the alveolar lung biopsy showing multiple Gaucher cells. What are the risk factors for pulmonary hypertension? Obviously, untreated Gaucher disease, total splenectomy. If they have the ACE1 allele, the family history, it's more common in females. And the N370S seems to protect against pulmonary hypertension, not quite clear why. So if you don't have it, it's a higher risk. There's some evidence that there's an increased risk of malignancy. There's definitely higher risk of multiple myeloma with a relative risk ratio of 5.9. And there are some reports of higher incidence of hepatocellular carcinoma and lymphoproliferative malignancy. There is at the moment no consensus, but most people would regularly monitor alpha-1 fetoprotein in patients with suspected hepatic lesions. If you look at the Gaucher registry, type 1, more common in there are more adult patients, whereas type 3, there are more pediatric patients. That, again, not surprising. Nutrition. These children can be very severely malnourished. These are two Pakistani children. This one was I actually saw in Pakistan. This one came to London, but they look almost similar. Very severe malnutrition, which seems to be unrelated to the underlying disease, but certainly one would expect that it would contribute to the morbidity and possibly the mortality. So in Lahore, the emergency treatment for these children is actually to admit them and put a nasogastric tube down and feed them first, so that they don't actually perish from severe malnutrition. There is a direct, coming to growth, there's a direct relation between growth rate and alterations, that should say Gaucher disease, so GD, not GR, and the alterations in the IGF axis, and ERT results in significant increase in growth. We talked about vitreous opacities. They can be asymptomatic. They present as floaters. They may interfere with schoolwork. So some children describe it as looking through a snowstorm. It's that severe. It may require a vitrectomy. If you leave this too long, you can get posterior vitreous detachment, sometimes even retinal detachment. And you may get secondary glaucoma, which I'm not quite sure what the pathogenesis is of this, but it's very resistant to normal anti-glaucoma treatment. And in 1 or 2 patients, they've had to put a tube in. I can't remember the name of the tube. Anyway, to drain, because medical treatment was not working. Kyphosis is almost universal in type 3. What's striking is that there is no vertebral collapse. So this is kyphosis without vertebral collapse. You can measure the angle of kyphosis. Lines drawn from the... Okay. All right. And you draw perpendiculars to this, and that is the Cobb angle. It's very easily measured, and I would really encourage that this is measured and recorded every time, because it's an objective way of monitoring. So we looked at a small number of patients with the Cobb angle, 12 patients who had 31 spinal x-rays at different ages, and all except 2 had an increased thoracic kyphosis, and none of them showed anterior vertebral wedging. And this shows you the data. So the blue line is the normal, so what we call the mean for age. As you can see, in normal children, the Cobb angle very slowly but increases over time. In virtually all the type 3 Gaucher patients studied, the Cobb angle was increased and kept increasing over time. So again, none of this is surprising, but it's worth seeing these sort of data. You can get mesenteric lymphadenopathy, which is usually an incidental finding. The biopsy usually shows atypical storage cells. When I say atypical, they look like Gaucher cells, but they don't have the same markers. So if you do immunocytochemistry, they don't have the same markers as you would expect in Gaucher disease. Okay? And we don't understand the reason. This is important because in some way they seem to be modified, and so is the modification the reason for their being resistant to treatment. There's no evidence of malignancy. So in fact, we stopped doing regular biopsies. We just monitor. Sometimes they may be symptomatic with malabsorption, usually fat malabsorption, as the lymphatics go through this. Sometimes you can get failure to thrive depending on the age and severity. You can get chylous ascites. Okay, so moving on to neurological features. Neurological features tend to be seen more commonly in younger children as opposed to adults. We've all seen this picture of type 2. The diagnosis of type 2 may not be easy, especially in the early stages. You can get opisthotonos, squint, and stridor. These are the three hallmarks of type 2. Now it's okay, these two children don't have type 2 Gaucher disease, okay, but this is a child with very marked opisthotonos. That's fairly straightforward, but in the early stages, it can be quite difficult. The squint, again, it is always a convergent squint. This child was missed, actually. So what happened was the abdomen was so rigid that the resident could not palpate the liver and spleen. So the resident wrote on the form, neurological, and the lab did the lysosomal screen for neurological disease. Now, Gaucher disease was not part of a neurological screen, so the diagnosis was initially missed, and it was only picked up later. So that's a clinical lesson. The squint is nearly always convergent, tends to appear early in type 3. Stridor, when encountered in a child with GD, you must consider a neurological cause. It's rarely an isolated finding, so you tend to see other neurological features as well. And it may be seen in type 3. Here you have a child with type 3 Gaucher who has a very marked stridor, and in fact you can see he already has a tracheostomy. You can also see that he has Parkinsonian features. He was D409H compound I think, well, he was compound heterozygote for D409H. I can't remember the other allele. So again, very unusual. He was rigid, but he also had this marked stridor. There is a very marked phenotypic spectrum in type 3. From this boy who presented quite early, developed myoclonic seizures and died at the age of 13 or 14. This is the Norrbottnian variety. This is the gentleman in northern Sweden. You can see the very marked ptosis. He hardly has any upward. He can't actually look up. Severe kyphosis. He's had total splenectomy. And this child, I think they were from Belgium, top of her class, very mild horizontal saccade abnormality, nothing else. It's important to remember that brainstem disease is the clinical hallmark of early neuropathic Gaucher disease. So I mentioned this child who came to us from Pakistan. He presented with lung disease, treated with tuberculosis, and he then developed a convergent squint, which was thought to be the result of anti-tubercular drugs, and then brought to the UK. And in fact, the squint was related to his brainstem disease, and the lung disease was Gaucher. That's his ABR with flat waves. So the ABR, so the brainstem auditory responses are nearly always affected, reflecting brainstem disease. At this stage, he had hardly any cognitive impairment. It was all brainstem. So we know that the eye movements show slow horizontal saccades. When a child can present like this, completely asymptomatic, it's very, very important to examine the eye movements, because the diagnosis of type 3 is clinical. There is no other way of diagnosing it. There are people who've done genotypes and say this is the genotype of type 3 Gaucher disease, but unless you show the clinical features, you cannot make a diagnosis. And that is universally accepted now. So you can assess saccades involuntarily by inducing nystagmus, which may be optokinetic or vestibulo-ocular, and we talked about this in clinic. So optokinetic is when it's voluntary. The child sits on a stool and the object goes around the child, and the child looks tries to look at the object as it's going around. Vestibulo-ocular is when the child is spinning around. And you can elicit it voluntarily in clinic. So this is type 1. How do I...
Video?
Just click. Okay. This is optokinetic nystagmus, okay? So the curtain is going around the child. Perfectly normal saccade. So it goes first in one direction and then the other direction. But when a child comes like this with type 3, it is very difficult actually to assess these. You can't expect them to sit on a stool and look at this curtain. You can hardly examine them. They're extremely irritable. This irritability is a very striking feature of young type 3 children. This is a child from Bangalore. So what you can do with these children, you can put them on the same stool, but you put them in the dark. Okay, you switch off the lights, and this recording is infrared. See how it locks? You see the locking and blinking? This child was impossible to examine in daylight, so we put her in the dark and looked at her under infrared.
Can you re-show again? Play the video again?
Yeah. See? It's you get the. Did you see the locking? She moves her eyes and she can't move them back. It locks like that. And she blinks. We couldn't elicit any of that in daylight. Now it's important to distinguish between smooth pursuit and saccades, and we've discussed this in clinic. So this child we've seen in clinic. I'll just show you her video. Oh, I don't know where it goes. Anyway, that is smooth pursuit, which is perfectly normal. Just repeat it for you. And this is saccades. And you can see she blinks the eyes when she moves from finger to finger. So smooth pursuit was normal in this child, but saccades were abnormal. And what often happens is that the child is tested only with smooth pursuit, as labeled as normal, and is labeled as type 1. With the often with the mutation homozygous L444P. But if you actually test saccades in the same child, you will find them to be abnormal. Saccades are always abnormal. They never become abnormal, okay? Whereas smooth pursuit can become abnormal. There is a bedside technique that you can use. You ask the parent to hold, in case the child is non-compliant and you don't have all that equipment, you ask the parent to hold the child at arm's length, and you get the parent to spin around quickly. It has to be quite quick. This induces vestibulo-ocular nystagmus in the child, and you observe the eyes for signs of locking. It sometimes works. It's worth trying. This is a 40-year-old gentleman who was diagnosed at the age of 4 with Gaucher disease and represented only because he'd heard about enzyme replacement therapy in his 40s. He had liver disease, he had icterus and stigmata of liver insufficiency, but nothing else. And he had, on testing, extremely mild abnormal saccades. And he had homozygosity for L444P. So the question is, how do you counsel this sort of patient? Because he's 40, and all his life, he was working, I mean, he had some disability and so on. And then suddenly he's told he has actually got neurological involvement. How do you actually manage this? It was very difficult. We had to obviously be honest with him, but it was very hard trying to explain to him that he actually had neurological. Then, of course, lots of questions, because his mother was, I think, about 70, and she couldn't even understand some of what we were saying. So that was particularly difficult. Fortunately, such patients are very few and far between. But, it's not a question of just doing a test in a clinic. You then have to deal with the family and explain the results of that test and what the implications are. So, how do you assess the extent of neurological involvement? You obviously look at the extent of the saccade abnormality, whether it's horizontal only or horizontal plus vertical. So the horizontal abnormality appears first and then the vertical. Okay? So if you've got vertical, that tends to denote more severity, greater severity. You look at the hearing, you look at audiometry. You have to check the ability to hear against the background noise. You look for myoclonus, type of seizures, whether they're myoclonic. Myoclonic seizures are particularly bad prognosis. You look for ataxia, and you look for Parkinsonian signs and symptoms. So the extent of the saccade abnormality has to be documented, whether it's horizontal only or horizontal plus vertical. So this is a diagram of the brainstem.
Slide.
The horizontal saccade.
हेलो सर माइक म्यूट कर दीजिए हेलो
Okay, so this is a diagram of the brainstem. The horizontal saccades are in the centers are in the pons, and the vertical saccade centers are in the midbrain. And I won't go into all these details, but just a couple of things. One is that the centers for the saccades and the gaze maintenance are separate. And that is possibly why pursuit and saccades are differentially affected. It's the same with horizontal saccades. The centers for the saccades and the gaze are separate. Now you can see that they're all in one line there. This is the reticular formation. The question is, why is it just the saccades that are affected and not the whole brainstem? It is, but much later. It could be that the disease preferentially affects these nuclei by affecting the brainstem. You see the same neuropathology in the mouse. But I think at the moment we simply don't understand why this striking abnormality appears first. Now, what are the audiometric abnormalities? They have bilaterally raised acoustic reflexes. I should say that the peripheral hearing tends to be normal. Okay? So don't just do a hearing test. This is called central auditory processing deficit. They have very poor brainstem evoked potentials. So this is the control with the 5 waves. You know that the normal BAR has 5 waves. And these are 4 patients with neuropathic Gaucher disease. You can see that there's flattening, just not as pronounced as normal. What is the role of BAR? Well, it's very difficult to actually get reproducible waveforms, so don't use it as a way of monitoring these children. It never improves. So therefore it has a limited role in clinical practice. If it's not going to improve at all, what's the point of going on doing it? It just upsets the child, it upsets the parents. So at our center we just stop. Oh. Sorry. Excuse me. My mother-in-law. Can wait. Sorry. Okay. So very limited role in clinical practice.
So do any of the types have skin ectatic changes?
Yeah, well, not outside the collodion baby syndrome.
That's what I'm surprised, that if the lethal form has such a severe ectatic form, so in milder form none of the...
No, because they probably have enough ceramide. I mean, ichthyosis is because of lack of ceramide in skin. So we stopped doing it, but it is useful as a diagnostic tool. So in very young children, when you can't actually do all these eye movements, do the BAERs, because they are always abnormal as well. And they correlate very strongly with the eye movements. So that is something that's easily done. The BAERs are widely available. So, as I said, the peripheral hearing is normal in spite of a normal ABR. Why is this? Because they have what's called an auditory neuropathy. In auditory neuropathy, you get preserved peripheral hearing and OAE with abnormal BAERs. OAE is autoacoustic emissions. Okay. This neuropathy can be caused by damage to the inferior hair cells, and this is seen in the chinchilla identical model, which is treated with carboplatin. There are two types of hair cells in the cochlea, the inner hair cells and the outer hair cells. The OAE, autoacoustic response emissions, depend on outer hair cell function. And this is normal in neuropathic Gaucher disease. Okay? Therefore, OAEs and peripheral hearing are normal in neuropathic Gaucher disease, except in the very late stages. So this is important to remember. There's a distinction between the IHC and OHC. So and then there's very poor medial olivocochlear suppression. And we'll come to that in a minute. So you can get, what are the clinical, sorry, in case I don't come to this, this is basically a suppression of background noise. So when you're sitting in a very noisy area, say a classroom, and somebody is sitting next to you talking, the way you listen, you hear what that person is saying is that your brainstem suppresses the background noise so that you can listen. That's what you automatically, that happens. Otherwise, if all of you are talking simultaneously and someone here is trying to say something, how do I listen to that person? You automatically switch off the rest, and you don't realize that you're doing it, but you do it. But these children can't do it, basically. And so everything, all noise appears the same to them. You can imagine how disabling that can be. So brainstem involvement. In type 2, you can get autonomic problems. So remember this, okay? They do not raise their heart rates. So even when type 2 patients have severe infection, they can remain bradycardic. So tachycardia is not reliable in type 2 Gaucher disease. Obviously the eye movements. Okay, so the Purdue pegboard is something we look at, which measures the dexterity for gross movements of the hands, fingers, and arms. There are 4 tasks, dominant and non-dominant, and it's heavily reliant on scanning on the eye movement. Okay, it's always abnormal in these children. 0, that is normal, that's the baseline, and they're all abnormal. So they have autonomic problems, eye movements, difficulty in hearing against background noise. And this is important in a classroom, okay? So what happens, sorry, the colors didn't come out funny, but anyway, so that's the teacher, students, back of the class. And you can see that in a normal class, the teacher's voice, the falls from about 80 decibels to about 50 at the back. That's the distance in meters. And that's the threshold for hearing. Okay, so once it falls below this threshold, the student cannot hear what the teacher is saying normally. But a normal child will lower this threshold so as to be able to hear the teacher. Type 3 Gaucher disease, they can't do that. Okay, so if they're sitting at the back, they cannot hear what the teacher is saying. So we always encourage them to sit at the front of the class. And because they have normal peripheral hearing, people just say, well, they're not deaf, so they're not disabled. So in the UK, we had huge problems with this. People don't recognize that these children's hearing is of a different, hearing loss is of a different variety than typical sensorineural hearing loss. So these children don't tick the normal boxes, okay? So all patients with NGD must have regular neurological assessments. So this is the first child we treated, actually the first child in Pakistan who required treatment. And I recently saw him in Lahore in a clinic, and this is in his early 20s, still getting ART. But you can see that he's got marked ptosis. He can't look up at all. He's got you can't see that, but he's holding his hands. He's got typical pill rolling moves with Parkinson's, basically. He's got the Parkinsonian facial appearance, which you see in type 3 more often than in type 1. Now, Ellen Davis, who worked with me for some time, developed this modified severity scoring tool based on a 4-year follow-up of chronic neuropathic Gaucher disease in several European countries. This was published some years ago. Oh, sorry, that didn't come out at all. Anyway, there's a spreadsheet, okay, and it's got lots of domains, and I can, this can be available as an Excel spreadsheet, and you can use this. And each domain has scores. These are weighted. And we developed this using a modified Delphi technique. Does everyone know what a modified Delphi technique is?
So what? No, but not modified one.
Well, okay. So modified means that we modified for that disease, and it's adapted to the disease. So we chose a panel of experts in neuropathic Gaucher. We gave them suggested a lot of domains, and we asked them to weight the domains, which were more important, which were less important, and they came up with a consensus. And you then look for similarity between the experts independently of each other, okay? And this is commonly used to develop scoring systems. You can read up about this, but that's how we developed it. It was published. They also get intention tremor. I don't know why it rotates, but you can see the type 3, very striking.
So in your experience, how many of the parents or relatives had Parkinsonism?
We haven't looked because the adults, parents are seen by the adult physicians in the UK. I think that's a very sensitive area. I don't know how you manage that actually. Yeah, I'm glad I'm not managing it, to be honest. So this
are
is.
we supposed to discuss with the parents this issue?
I never do. I only discuss the child. Because I think, it then becomes very confusing. I think the parents should be spoken to as patients by someone else. That's better to keep it separate. So this is ataxia. I mean, what is striking about this child is that his cognition was almost entirely normal. But he had these marked cerebellar signs. So you can get this discrepancy. What is the impact of neurological involvement? Obviously, the eye movement disorder can have an impact on mobility, on reading, on safety. They can't run around very easily. They can have seizures. The problems with hearing against the background noise. Myoclonus, including hypnagogic myoclonus. Hypnagogic myoclonus is myoclonus which occurs as you're falling asleep. It's quite common, well, it's not uncommon in the normal population, but it's much more common in these patients and very, very severe and quite disabling. And they get worried, of course, because they think it might be part of their disease. Well, it could be that their disease is predisposing them to this. The ataxia can be very disabling. Obviously, if they have Parkinsonian signs. And psychiatric, now this has only become more recently evident. They have a lot of psychiatric problems. So we looked at a small number of children at Great Ormond Street, 7 children, and we found a variety of problems. They had learning difficulties and clumsiness. They had a low mood, not in all the children. Manic episodes. They had oppositional defiant disorder, impulsivity, depression, obsessive compulsive, quite a wide range actually if you look. And you can
obsessive compulsive already described. Okay.
So you can also do, we didn't publish this, so you can.
No, I didn't,
because
you had that it is a known
we saw one patient who had.
Yeah, so we didn't know that this is a known association.
Yeah, it's.
So the frequency of these is equal in type 1 and 3?
We didn't do matched cohorts. We only studied type 3, so I don't know the answer to that. My personal view is that it's not. I don't think it's as common in type 1, but I don't think it. I haven't studied it. It's a good question. It's also important to remember that 50% of parents displayed levels of distress warranting professional attention. Okay, we mustn't forget that we are treating families, and obviously as geneticists I don't need to tell you that, but we must always pay attention to the profound impact of this condition on the parents. So these are just some descriptions. I've anonymized them. We did a DOBA, which is a standardized assessment of psychiatric evaluation in behavioral problems in children. So I read it. The results from the DOBA highlighted that, this is the name of the child, I've kept it blank. She has some significant areas of difficulty. This is particularly in areas around social phobia, agoraphobia, generalized anxiety and depression, social communication difficulties. She needs to be monitored appropriately. Strong thoughts of self-harm. She had actually attempted self-harm on 3 occasions.
What is agoraphobia?
Those cases.
Open spaces. Open spaces. Yeah, it's the opposite.
Claustrophobia is
Claustrophobia is closed and agoraphobia is open space.
Yeah.
Crowded open space.
No, just open spaces.
Just open.
So here's another one. Again, very different. Functioning well. Concerns were raised within the DOBA and the PONS. The PONS is the parental, it's something to do with the parental questionnaire, basically, regarding low mood, worries, and fears. So, what about school? They have difficulty in hearing against background noise. They can't look up, especially if they have a vertical gaze palsy as well, they find it very difficult looking up to the board. So we tend to give them tablets or iPads. They can find working on the computer very difficult because especially if they have to look from the keyboard to the monitor and they have to keep looking up and down. moving between classrooms can be problematic because of the ataxia, the eye movement problem. So what we tend to do is we give them time. We allow them to leave the class 5 minutes before the bell rings so that they can quietly go to the next class instead of having to rush along with all the other children. They have learning difficulties and therefore they have special educational needs. Young adults can have problems. They have special needs at college. They have problems with executive function, healthcare issues, independent living, dressing and undressing, dealing with money. I've seen these children. We brought 2 or 3 of them to India a few years ago, and we took them shopping, and they opened their purse and they were having great difficulty in actually manipulating the money because of their intention tremor. Okay, so this is the sort of problem that adults have, or young adults have. Obviously in busy or noisy venues, driving is almost impossible because they simply can't look from side to side. Now this is a very particular subgroup. This was taken, I visited the clinic in Jerusalem some years ago. This is one of the clinicians there, Ayala Abramov, with these 2 young siblings actually. They're Palestinian Arabs, and they have a particular mutation, the D409H homozygosity. She was the first to describe them from Israel, along with a Spanish group in the same year. And what they get is this porcelain aorta, this heavy calcification of the aorta, and they die of this. They have minimal visceral and neurological disease, but they have this. And it's still not clear why. They have the enzyme defect, but this is their phenotype. So they need cardiothoracic surgery. And it's very sad because in Israel, quite often these patients are second-class citizens, they're Palestinian Arabs, and they often don't get the attention and the surgery that they need. So we'll move on to management. Do people want to take a break?
Maybe 10 minutes later, their चाय का पानी गर्म हो जाए तो नहीं अभी 9 o'clock he opens, so in 5 minutes probably we can get a tea.
All right. You tell me when we want to take it. Then I'll phone my mother-in-law as well. She must be wondering why I'm not phoned her back.
अर्चना देख लोगे कि उधर चाय.
Okay, so general management.
So agoraphobia is actually extreme fear of open or public places. So both are correct. So public places is crowded.
Okay. So how do we manage type 2? It's one of the most difficult conditions to manage because typically you get the child, you make the diagnosis immediately, and then you're supposed to say something encouraging to the parents. But really the management is diagnosis, counseling, support. It's very important to get samples from the child so that prenatal can be offered in subsequent pregnancy. I don't have to tell you that. You should manage their seizures.
Excuse me? So, can I ask a question?
Yeah.
With availability of ERT for type 1 especially, so in UK will the family opt for prenatal diagnosis and terminate the affected one?
That's a good question. So prenatal in type 1 has almost disappeared in the UK. Yeah.
So they would diagnose after birth and put on treatment as a
Exactly. You should manage their seizures. Swallowing difficulties, they all get swallowing difficulties because it's brainstem disease. So early nasogastric feeding, early gastrostomy, and stop saliva production. We discussed it with San Filippo yesterday, same type of management. They all have stridor very early, so consider early tracheostomy. This they find very difficult to accept, but it can be well, when I say life-saving, it prolongs life, and you could argue, is there any point in prolonging life? But there is, because in the early stages, these children have these very catastrophic stridor episodes, which are very frightening, both for the child and the parents. And the child is aware of this. So I think it's justified to do a tracheostomy in these children, just to make life a bit more pleasant for these children, for these families. So here you have a child with type 2. Because the worst thing is for a parent, the child is at home, has this glottic spasm and does not recover and actually dies in glottic spasm. That is very traumatic for the family. How do you manage kyphosis? So it depends on the angle and flexibility. We talked about flexibility of kyphosis, whether it's flexible or rigid kyphosis. So we consider bracing. These are just general considerations, okay? If the angle is less than 65 and it's reducible, and there is at least 1 year of growth, you should continue with bracing until growth is complete. Consider surgery if it's more severe. The impact of curvature may be affected by respiratory involvement. Obviously, if they have severe kyphosis and they also have restrictive lung disease, then the impact of both can be sort of double. So this is a typical brace. It's called a Milwaukee brace. How do we manage lung disease? Do you want to stop or keep going?
Just okay. अभी we'll get a tea like 12.
No, you can carry on.
सब लोगों के भी 12 ठीक है अर्चन मेरे नाम से इसको जमा करने के लिए
I'm president of
You had it post press conference. I read the article.
When?
After the conference.
क्या है
Just to debate
American Heart Association.
God.
I saw
Corner.
he's just 53
But he has a very strong
Familyist.
वो बेचारा सब लोगों ने writing out in all likelihood he followed NHA guidelines, मतलब NHA guidelines. मतलब उसके लिए मतलब.
Is he okay? God.
More so because he's president of AHA, so everyone is.
Yeah. It's gone viral, has it?
So वो था ना कि this दीपक चोपड़ा का कौन था ना? Always writing on the positive thought process and all. So he committed suicide. हाँ तो वो भी है ना the people of
Who is Deepak Chopra?
Deepak, he's written all these self-help books.
The whole na कि how to think positive, how to stay happy, how to
Yeah, I don't read it. I say the titles.
Titles na.
Yeah.
7 ways to live happy and then 10 ways to live happy and all that ultimately. So one of the comedians भी sir, that comedian last year उसकी death
Rob Williams.
वो उससे committed suicide.
Rob Williams.
हाँ.
Robin Williams. Yeah.
He died of depression.
Yeah.
Bipolar disease.
He had bipolar, no?
Bipolar disorder, yeah.
No, but he had these diseases also, I think. He had liver disease first. Yeah.
Really?
He got it dementia. He had.
Yeah, that was sad actually. I loved his films, really. Take care, I'll phone my mother-in-law.
She's in Trivandrum.
Huh?
She's in Trivandrum.
She is in Kerala, yeah. Okay.
All he's doing.
It's 1st December.
क्या बना रही
Exhibition आ गया ना? कैसे मना लिया?
series start होके AIDS पे पहुंच गए. Actually हम series होते हुए AIDS पे पहुंच गए थे.
मतलब
HIV पॉजिटिव है ना हमारा और उनको डिस्कस होते होते हम AIDS पे पहुंच गए.
इसके साथ
आए थे ना 11:30 बजे
क्या हो गया सर
उन्होंने कल रॉन्ग नहीं लिया था।
कल रात को 12 बजे ऐसा?
अभी ये मेरा व्हाट्सएप है, वो मेरा पता नहीं
जो भी
कौन है।
दीप्ति मैम को भी हो सकता है।
चलिए सुन लीजिए।
को इन्फॉर्म करना शुरू कर दो बाय
अच्छा, मैंने उसको एडमिट करने, पेशेंट को आज एडमिट करने के लिए कहा था।
पवन
अवन प्रेम लता देवी।
अरे पवन
कल 22 वीक्स है, मैंने कहा अभी भी करना है तो उनको करना है। नहीं, उनको मैं बता रही हूँ ना, एक्सेस टू टर्मिनेशन इज ऑल्सो डिफिकल्ट। मतलब गायनेकोलॉजिस्ट ध्यान देने को तैयार नहीं, इनके पास पैसे नहीं है, दे डोंट दे। बट तब गए थे तो 16 वीक्स थे, 16 वीक्स ही थे। बट टू रीच एट राइट प्लेस, द पर्सन कंसर्न शुड अंडरस्टैंड। They said that she is so anemic. Why will, मतलब gynecologist का ये कहना था, why should we take risk of doing MTP for such anemic woman? मतलब nobody like कुछ उनको भी they cannot communicate also. They also understand very little. मुझे लगा it was not really कि उनको लगा फिर ठीक है जो हो रहा है।
अभी भी लेकिन हम एक बार ट्राई कर सकते हैं।
बट कौन
सी वगैरह भेज सकते हैं।
बट उनको पक्का चाहिए हो तो पूछ ले फिर, ताकि फिर डॉक्टर अमिता से वगैरह फोन करके पूछ लूं कि क्या कर देंगे, क्या इनको करना है कि नहीं, पक्का बता कितना खर्च आएगा। तो फिर केजीएम से, बिकॉज रियली मतलब आई फील बिल्कुल ही
नो प्रीवियस सिजेरियन बड़े आराम से।
हाँ कोई नहीं ना, एक बार मैं अमिता से पूछ लेती हूँ, फिर इनसे पूछ लेना।
बट हमें फिर रिपोर्ट देनी पड़ेगी ना उनको।
अफेक्टेड वाली तो दे देंगे, 22 वीक्स वाली रिपोर्ट था, रिपोर्ट तो बना के दे सकते। तब भी ना some people from lower socio-economic strata, less educated, are more smart. So he is like very so इस वजह से कि and he like ना कि वो जो दूसरे बच्चे के प्रॉब्लम से भी वो ऐसा वो हो गया है कि वो जो जिसको ascites है
उसको पीच गेस्ट्रो रेफरेंस कराना है ना।
हाँ, वो ज्यादा से ज्यादा ड्रेन करेंगे
लास्ट टाइम उन्होंने वही
एक बार। लेकिन वो रेडियोलॉजी में पूछ लेती हूँ कि वो मतलब गैस्ट्रो वाले को नहीं लग रहा है बच्चे आ रही कि रेडियोलॉजी वालों को करना नहीं है स्टेंटिंग। रेडियोलॉजी वाले स्टेंट डाल देते हैं। तो व्हाट इज द सिचुएशन? एक मैं पूछ रही थी, मतलब अभी टाइम है कि नहीं,
वो बच्ची आ रही है, वो कह रहे हैं सेकेंडरी हीमोक्रोमेटोसिस की वजह से है ना, मतलब उस तरीके से बाय टाइम एंड अगेन जैसे कि वी हैव ट्राइड।
नहीं, बट हम रेडियोलॉजी वालों से पूछे ना कि उन्होंने ऑब्स्ट्रक्शन डॉक्यूमेंट किया होगा तो होगा ही, अगर नहीं
किया डॉक्टर राजकुमार के साथ में
नहीं, बट रेडियोलॉजी वालों ने भी ये पूछ रही थी मैं कि वो जो हमको कॉन्फ्रेंस में जो है ना त्रिवेंद्रम वाली, मैंने 1-2 बार फॉरवर्ड भी किया था कि देयर इज एन ऑप्शन ऑफ प्रेजेंटिंग इंटरेस्टिंग केसेस, मतलब देयर वाज, आई डिडंट नो, बट रिस्पोंडेड मेरे को भी, आई डिडंट गेट टाइम टू अप्लाई माय माइंड। कुछ इंटरेस्टिंग केस अभी भी हो तो प्रियंका और मतलब किसी ताकि वी कैन अगेन आस्क डॉक्टर शंकर की कोई स्लॉट बचा हो तो 3-4 मिनट टाइप का, बट देन द केस हैज टू बी रियली इंटरेस्टिंग। जस्ट ऐसे कि एग्जाम की और म्यूटेशन मिला का ऐसा कुछ नहीं चाहिए, आइदर वेरी रेयर फिनोटाइप या क्या है। तो मुझे मतलब ज्यादा किसी का भी ऐसा हो कि जिसको हम, या फिर उसमें कोई विजुअल इमेजेस या समथिंग ऐसा कोई पुराना भी केस हो। तुम्हारे इसमें वो वाला केस तो तुम्हारे उसमें ही है, माइक्रोपैलिस्टर किलियन वाला, तो इस वजह से वो नहीं, बट कोई और वो ध्यान में आता है तो अभी मैं लिख रही थी डॉक्टर शंकर को कि अभी मतलब whether he has got enough cases or not, but पहले तो हमको पहले अपने पास कुछ है कि नहीं प्रेजेंट करने वाला, something really interesting है सर. प्रीनेटल में से मुझे याद ही नहीं आ रहा कोई, इतने में हमने प्रीनेटल में जो इमेजेस, बट मेनली इतने में हमको जो भी अच्छे प्रीनेटल हुए उनके वो भी नहीं मिले हैं, उनके फीटस नहीं इस टाइप का कुछ हो जो नहीं. बीच में हमने वो इमेजेस स्टोर कर लिए थे 2-3 इंटरेस्टिंग वाले, क्या था किसी का कुछ याद नहीं आ रहा.
और ये आईएस कर देते हैं वो तो नहीं करना.
अरे वो
ये
तो
इसमें क्या इंटरेस्ट?
मतलब कॉमन टाइप के ही है.
वो पेशेंट का अभी डिलीवर नहीं हुआ,
कौन सा?
वो जिसके पेरिनियल वो है मैम.
ऐसा वाला नहीं है तो एक जो एक आया भी तो था जो पेरिनियल हाइड्रेशन
वो तो बहुत बार आ चुका है.
हाँ, किसी तो आया था, किसी ने तो किया था, थोड़ा मतलब पुराना है.
कौन सा?
पेरिनियल हाँ, पेरिनियल बहुत जैसा बाहर निकला हुआ था.
Okay, so basically antibiotics are ineffective unless there's superadded infection. So the way to treat them is with a combination of oral and inhaled steroids. So in all children we start prophylactic inhaled steroids, and we then give short courses of oral steroids for the acute episodes, usually it depends, about 2 milligrams per kilo, about 5-day course, just very short courses. And it's important to give perioperative oral steroids because they get this post-operative hypoxemia. So if you know they're going for elective surgery, start oral steroids a few days before. And on the background of enzyme replacement therapy, it gradually improves. So we find that the need for these repeated courses of acute of oral steroids reduces over the year, but it takes years sometimes. Remember to measure diffusion capacity when monitoring lung volume. What is diffusion capacity? So this is the inhaled air, which contains about 0.3% carbon monoxide, and exhaled air should contain about 0.15% carbon monoxide. And if there's a discrepancy, if there's a diffusion defect, obviously this figure will go up. And depending on the degree of diffusion abnormality, that can be graded. So 100%, 80%, 40%, that's how they do it. As a percentage of normal is how they normally describe it. I don't know how the pulmonologists here do it, but that's what I'm used to.
Excuse me, so they have more of interstitial lung disease?
Yeah.
Not much of obstructive element.
Right,
But
so
they are sort of helped by steroid.
yeah, if you do standard spirometry, it's quite often normal in the early stages. It becomes abnormal later, but typically the DLCO, this test, is abnormal first, and then spirometry. So diffusion capacity is more sensitive than standard spirometry. It does need an adequate lung volume, about 1 liter, and that is a problem. You usually don't attain that till you're about 10, 12, or well, maybe a little younger. Now, lung involvement may be subclinical, and therefore regular monitoring is required, and it may persist despite enzyme replacement therapy. So the lung, the alveoli, seem to be a sanctuary site, like the mediastinal lymph nodes, mesenteric lymph nodes. And additional therapy may be needed, for example, small volume, a small molecule, sorry. Mesenteric lymphadenopathy, as I said, it's usually incidental finding. Biopsy shows atypical storage cells. There's no evidence of malignancy. It may be symptomatic. It's refractory to enzyme, and there are, however, recent reports of success with a combination of substrate reduction with miglustat and oral plus minus oral budesonide. I'm not sure why, but certainly there seems to be a different pathogenesis in this tissue. Now we come to specific management. There are 3 types of specific management currently available: bone marrow transplant, enzyme replacement, and substrate reduction. So, is there still a role for BMT in the management of Gaucher disease? So I thought it was worth going through some of the data from the early transplant patients. This was the first report, or one of the first reports of transplantation for Gaucher disease in 1987 from Jack Hobbs' group at the Westminster Children's. You can see the dramatic change in the bone marrow. Pre-BMT, these are actually slides of transparency, so the quality is not great. Pre-post, normal hematopoietic marrow has started to appear. This is within months of transplant. The glucocerebrosidase typically shoots up like that and then comes down to within the donor range. So the donor may be heterozygote or unaffected, or unaffected. Depending on that, the level may be 100% or 50% of normal. The chitotriosidase comes down to perfectly normal. So these are a small number of children, and you can see in all cases the chito came down to perfect. And this you do not see in enzyme replacement. So it's very dramatic. This is a child who had a fractured neck of femur pre-transplant, and without any other treatment, a year post-transplant it healed. And again, I have not seen this on enzyme replacement.
So with ERT, Kaito comes down, but it never becomes normal.
I've seen it normalize in the only in one child, but not as dramatic as these patients. And that's Samantha. That's the child with the fractured femur, and she was able to stand straight and walk. Splenectomy. Now, if you're going to do a transplant, you need to do a splenectomy before transplant. And why is that? Because if you don't do a splenectomy, they do not recover their counts. So you know, after a bone marrow transplant, the white count, platelet count falls and then gradually recovers. If you've not had a splenectomy and they have hypersplenism, the counts never recover and they die of hypersplenism and neutropenia, thrombocytopenia, infections. Technically,
Excuse me? So, because you must have been involved in those early cases of BMT. So this was like after doing some BMT, people realize that this happens.
Yes, exactly.
Because otherwise, in routine course, everybody is always to prevent defer splenectomy as much as possible.
Yeah.
After
So we were
doing BMT, you realize that it happens.
That's right. And then we started doing the transplant, the splenectomies, and we found that they went through without a problem. There are problems with splenectomy, of course. So we prefer partial to total. In type 3, if you do a total splenectomy, it accelerates the neurological disease. And generally in children under 5, we prefer not to do a total splenectomy. But a partial splenectomy is more risky. So what you might want to do is a short course of enzyme replacement therapy, which then shrinks the spleen. So it's like a medical partial splenectomy. The child going in for, I was actually present at this partial splenectomy. And this is the problem. So that's the splenic artery and that's the splenic vein. And the circulations don't follow each other. You can see that. So if you start dissecting along one, you will miss the other or rupture the other, you know. So what the surgeon did was he had on his cautery, he had a Doppler. So as he was cutting, the Doppler was looking for blood flow. And as soon as it sensed a large vessel, it beeped. So then he stopped and he was able to carefully dissect and isolate large vessels. And this way, actually, this child did not require transfusion during the splenectomy. It was a bloodless. It was quite dramatic, actually. But a lot of surgeons feel that it is technically more difficult than a total splenectomy. So we do have problems convincing surgeons about this. So moving on to ERT, I'll go very quickly through this. This is well known. There are 3 commercially available preparations. It's highly effective in the treatment of many non-CNS manifestations, but there's no evidence that the CNS is reached.
Excuse me, can I ask one question?
Yeah.
For this now Gaucher, there are 3 companies making enzyme. So over years, has the prices come down for at least ERT of Gaucher in UK and other parts of the world?
No.
Because
don't ask me why not, but the answer is no. And yeah, I mean,
because at least there is some competition. Because the
there is
prices
competition. Yes, that is
But
right.
among all ERTs, Gaucher is the cheapest.
That is true. But in the United Kingdom, for example, velaglucerase is now the one that has to be prescribed first.
Because it is the cheapest.
Slightly cheaper, along with the home delivery costs. So that the package is slightly cheaper, so they have to prescribe. So
is the difference very slight?
No, very slight.
So just like, so you had, the
Just
prices
enough.
are open, or do we have to tender like in India? Because
No.
like in case of hemophilia, like we did with tender, and
Yeah.
their prices of course must be fixed, but they can quote lesser than that for our tender. and naturally because of the competition, the prices of recombinant factors have come down to as close as plasma derived factor.
Yeah.
So we insist, because otherwise this recombinant factor was very, very costly. And as a policy, at least as myself and some other recommended that we will buy the cheapest one, not give preference to the recombinant, because cost is too much and the difference is not that significant.
Yeah.
So because of that, the competition, the prices of recombinant, they reduce so much that they are almost as same.
Yeah, I think the only way, one way forward is biopharmaceuticals. The problem with that is that the glycosylation of these lysosomal enzymes is very challenging when it comes to biotechnology.
But once now this is quite a long history, so now the funds involve investment in the research, and now the cost of production must be very, very small.
Yeah, you would think so. I'm not party to those internal discussions. So these are therapeutic goals that have been published. So these are, you can read them. So regarding to the hemoglobin, spleen, liver volume, spleen volume, how much to expect over a period of time. Same thing with skeletal, pediatric, what you would expect from growth and puberty, etc. So there are endpoints that have been developed. I'll go figure that. So moving on to substrate reduction therapy, there are two preparations available, miglustat and eliglustat. At the moment, eliglustat is preferred.
Excuse me, can I ask one question again?
Yeah.
So, do the liver spleen totally become normal in size after a few years, or
No.
at least in some patients?
It depends on how much pathology there's been in the spleen. So if there's pathology there that's not amenable
Irreversible.
to, then it won't get smaller. So if there are infarcts or Gaucheromas, and so then it's not going to reduce. But if it's just
it decreases, then does it become almost of normal size?
Yeah.
Totally not palpable.
not palpable but not normal. So it's still enlarged but not palpable. So that's the step. Okay, so glucosylceramide is the substrate for glucocerebrosidase, and this is the enzyme that produces it, and that's where the block. So substrate reduction acts by inhibiting this enzyme and reducing the formation of this substrate. 3 phase 3 studies, ENGAGE, ENCORE and EDGE, different types of studies. But it's important, so I was talking about substrate reduction and lung function. When we did the study many years ago on miglustat in the treatment of type 3 Gaucher disease, it showed no effect on the CNS, but the lung function improved. You can see in FBC. So we thought it was just about the only thing that improved in this study. So the question is whether substrate reduction, i.e. eliglustat, could be useful in Gaucher lung disease. So here we have a patient. She presented, so we started her very early. So she's been going on that. That's the FVC and that's the FEV1. Okay. She went on the miglustat study, and both of these dramatically improved. You can see that. She was already on very high doses. She's on more enzyme than anyone else in the world. Okay, she's on something like 230 units per kilo of enzyme. And
Can
yet,
it be increased so much?
exactly.
So how was it monitored and why was it increased?
So what was increased? Oh,
Enzyme. Because
so that's a different.
recommended is 60.
Yeah. So we managed she was the one who developed mesenteric lymphadenopathy, and we persuaded the health authority at that time, this was 20 years ago, 15 years, to increase the dose. And she also developed infiltration of the base of the skull with hearing loss. So her skull looked like sort of pepper and salt. And we thought it was beginning to disintegrate with extensive erosion. So we got quite worried about her. She also had multiple pathological femoral fractures. So we increased the dose, and she stabilized. And since then, she's been okay. Anyway, the point is that on the background of such high enzyme dose, still her lung function improved on miglustat. That's the point. So this is as percentage of normal, okay? So from very low, 55%, it went up to 70%. Then so that's the duration of miglustat. And then we stopped miglustat, and then her levels plateaued. And then here she presented with pneumothorax. And you can see at this stage her things started falling. She had a VATS procedure as well. Sorry. Okay. And I don't have follow-up yet on her, so we started aliglustat at this stage. We got it on compassionate basis. She was just about an adult. And what this doesn't show you is after this, on aliglustat, these started coming up.
Excuse me, one more question. Do we measure the enzyme levels of those patients who are on ERT, and if they are not responding, and will the same test which you are doing for otherwise enzyme assay will measure the serazyme level or whatever? So that will
little different.
So long-term follow-up, 4 things to remember: kyphosis, respiratory, neurological, psychosocial. Never forget the psychosocial impact of management of these patients. So these are the three young ladies whom I've managed over the years, and you can see that outwardly they look fine, but there are various degrees of maladaptation. This is the young lady I was just talking to you about who had the very severe skeletal disease. She's now at university and doing very well. This is the lady who had the massive spleen and partial splenectomy. So we have to continue managing them as young adults. And you can see when they present to university or a place of work, somebody looks at them and say, well, they look fine, what's wrong with them? But they have all sorts of subtle problems. They may have emotional problems, and all these have to be managed. So it's not simply a question of giving enzyme to these patients. So newer treatments for Gaucher disease. This is a small molecule Genzyme study for type 3. That's what it's called. There's gene-augmented HSCT, so we discuss this under newer treatments, how to hyper-express the enzyme using virus gene-driven expression. That's the company that's producing that. Heat shock protein. We talked about, remember heat shock protein 70. So this drug is called arimoclomol, and the company is Orphazyme. And in fact, they've got an ongoing study in Niemann-Pick C as well. So this study is just opening. And harnessing nutrient sensing. So we've talked a lot about nutrient sensing. I know it's probably the most difficult aspect of basic science to grasp, but it's probably one that's really beginning to open up. So let's just talk about that yet again, briefly. So we talked about this. So here you have the lysosome, and that's the nutrient sensing apparatus with the mTOR, TFAB, which under conditions of starvation, it dissociates from mTOR, flips to the lysosome, and switches on transcription of your lysosomal genes. Now, that's all fine. But if you have a lot of starvation and a lot of lysosomal stress, as in a LSD, this upregulation of the lysosomal enzyme doesn't compensate. So how do you reverse this? Well, people have tried giving TFAB and getting it back to mTOR to bind to the lysosome again, and that can help, but not always. So this was described just last year. Drosophila, they created a model of neuropathic Gaucher disease. And this demonstrates lysosomal and autophagic defects and altered mTOR signaling. It's functionally rescued by rapamycin. And Drosophila has two orthologs of GBA1, that's the gene in Gaucher. And the knockout, this particular knockout, displays neuropathology, which is very similar to NGD, and which is partially rescued by rapamycin. What is rapamycin? It's also known as sirolimus. It's a macrolide, and it's actually used commercially to coat coronary artery stents. So obviously there's a difference between doing that and treating Gaucher disease, but it's interesting that it's commercially available. So that's Drosophila. These are the two genes, D, so for Drosophila, GBA1B and GBA1A, two genes as opposed to just one gene in humans. This is not an important gene in this particular consideration. It's this one. So knockout of that gene, you get defective lysosomes, defective autophagy, abnormal mitochondria, all this neurodegeneration. And if you give rapamycin, it partially corrects some of these deficits. So that's interesting that, and so going back to this diagram.
So this model is same that in oncology we use in mTOR pathways hyperexpressed than this mTOR inhibitor rapamycin.
Really?
This
Okay.
is in practice in oncology.
Okay, great. Okay.
Yeah,
so-
and all for tuberous sclerosis and other rasopathy group of these, so these pathway-based medicines. So
it's not a
NDK inhibitors and mTOR inhibitors. They are-
right.
For
So
neurofibroma especially, they have recently shown that all plexiform neurofibromas, they just disappeared in 2016.
well, maybe there's this may be a way forward. I don't know. We'll see. Okay, so last slide. So this is how to diagnose type 3. How to correctly examine horizontal saccades. I think this is a very fundamental point. The genotype-phenotype correlation and its disadvantages. How to plan treatment for an individual patient. As you can see, it's not just about giving enzyme, there are many other aspects. And new treatments, so which one is most likely to work for type 3? Thank you. Do you want to open it up, see if any of the other centers have questions?
So for Niemann-Pick, Niemann-Pick C, are there any, it's not very useful, no? The medicine, whatever I reviewed.
Yeah, so Monday is the Niemann-Pick C talk, so we can discuss that. So, questions?
So, Inusha, any questions?
Morning, sir. Sir, is there any follow-up protocol for monitoring these patients?
Yeah,
Usual
so we've been discussing some of that. How to monitor visceral disease and how to monitor neuropathic disease. So there's a neuropathic scoring tool severity scoring tool to record the neurological signs and long-term monitoring, but also the various aspects of neurological and non-neurological disease, how to follow up. Did you see those slides, like kyphosis, lung disease? So I identified 4 non-neurological, that's kyphosis, lung disease,
Psychosocial.
yeah, and in the short term, obviously there are many things that you should look at, but the long-term follow-up should probably be focusing on 3 or 4 aspects. This one I can't see.
Camera on the direction.
Camera is that's there.
Yeah, they are there because I can see the shadows and it's.
So they need to adjust their camera, or we
Yeah,
need?
they need to.
Okay.
So, Dr. Inusha, was the audibility satisfactory for this session?
Yes, madam. Only in between few the slides were not clear. Otherwise, most of the slides we could see and hear properly.
Okay.
And even the discussion in the break period. Maybe you are not muted that your speaker.
No, I was telling that Inusha and Sheetal were together at one point. Then they said no, they were not together in PGI. Like you are from different batches, no? But in this Chandigarh they were together. So that was because all these students don't know that Dr. Inusha was also in PGI at some point of time. So I just always introduce my students with pride that they are at different places, like Sumita at CMC, Inusha, Sheetal is now heading a very important post.
Actually, I wanted to say that you should update on the website the old
so now
consultants.
this recently we updated all information about our department because PGI wanted everything together. So now that will be so the information is compiled. Probably we had your address. Now we want photographs of all alumni. So yeah, will be writing you there is an email to send your photographs. So now we are going to update that also.
No, actually regarding the consultant in SGPGA, that also I think should be because Kaushik's name was not there.
Yeah, so what the PGI ki website, that is why PGI ki website they are updating. So they wanted us to give all the information. That's why we compiled everything. Let us see how they do it soon.
So there was something I wanted to say, that was we were going to continue on Tuesday and so on, but because I'm leaving on the 5th, the talks that I had planned for the 5th and 6th, we need to decide how many, whether and how many to give.
Yeah,
so
I think some plan here.
camera
Because on Monday we had one presentation from our department of journal clubs because that is usually on Monday. So of course that can be changed with your topic. So that is obviously. So one topic will be taken care of on that
So should I
session.
revise the plan?
Yeah, so you can discuss together and let them know. So Dr. Inusha and Dr. Soni, the next session will be on Monday morning, and then Tuesday you will be leaving. So early.
Monday morning.
So Tuesday Dr. Velody will be leaving. So from Tuesday we had previous according to plan we had some session on Tuesday also. Now that stands cancelled. So for topics we can inform, but basically on Monday there will be both the topic lectures by Dr. Velody and not like one presentation from our department.
Thank you.
Gangaram has one question.
Gangaram.
Dr. I.C. Verma is
they can't
also
see.
there. I.C. Verma,
तो
Dr.
बताओ ना
Ratna.
मैं उनका
बोला मैंने।
कैमरा ठीक करो।
बोला मैंने उनको सबको खड़ा होना पड़ेगा.
नहीं क्या अच्छा।
So
So they had a question that what is the recommendation of bone marrow transplant for Gaucher disease in India? What should be the recommendation?
So the question is, what is the should one consider bone marrow transplant in India? I mean, that's a very pertinent question because enzyme is in short supply, and we know that many children may die if they don't receive enzyme in time, because especially very young children severely affected. It seems, I don't understand, but they can be stable for months and then very suddenly and dramatically deteriorate with thrombocytopenia, rapidly enlarging spleens, and so on. So if we are unable to get enzyme for especially this group, there may be a case for a bone marrow transplant. Whether we could give, in such children, whether we could give a small amount of enzyme pre-transplant to reduce the splenic size and prevent post-transplant persistent cytopenia, well, that remains to be seen. We would need to approach Genzyme or Shire. But I think that group is certainly very vulnerable. And we know that the results of transplant, the outcome, the morbidity and the mortality has dramatically improved over the years. So I think, we could consider that. If we can't get enzyme, then we have to consider partial or total splenectomy. And in that case, remember that they have to be protected with pneumovax and so on, the usual anti-infective procedures.
Usually for vaccination we use like Pneumo PCV13 followed by the routine Pneumo 23 for pneumococcal vaccination. And usually patients here, they are diagnosed at like age of 1 year, 2 years, like that. So they are less than 5 years of age and have severe form of the disease.
Yeah, I think one of the things you have to remember with pneumovax is you have to prime the B lymphocytes in time. So if you do it just the day before splenectomy, it's not as effective. You have to allow, you have to plan it for a few weeks before splenectomy. Yeah.
Thank you so much.
Thank you.
Meet on Monday next.
Monday.